Public Health, and I run our Grand Rounds program, and we are delighted again to have Dr. Rimal today. We have a great winter and spring series coming up for Grand Rounds, as you can see. Diana Robbins from Georgia State University will be talking about her work in autism. Sandro Galea from Columbia will be talking about some of his interesting global health work. Bobby Reiter, President and CEO of the National Center for Farm Worker Health, will be talking about migrant worker health. And Susan Reverby, for those of you who've taken my class, have read her book, will be joining us to talk about the Guatemalan syphilis study, and that will be in April. So thanks again for coming out. Without further ado, let me bring up Chair of Community Health and Prevention, Associate Dean of Research, Dr. Ann Clausen.
Hi. It is very nice to see you all here today, and an extreme pleasure for me to bring to Drexel for the day one of my close friends and colleagues. So Dr. Rimal is an associate professor in the Department of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health in Baltimore. He's also senior evaluation officer at the Center for Communication Programs at Hopkins. Dr. Rimal got his master's degree in journalism and mass communication at Southern Illinois University, and then went on to get a PhD in communication from Stanford University with a minor in psychology. He's former chair of the Health Communication Division of both the International Communication Association and the National Communication Association. And he's worked for over 15 years in health communication and especially in risk communication research. And his work seeks to understand how individuals across a variety of cultures and countries process information about risk, and how the societal norms around them influences their behavior in response to risk communication. His current work focuses on developing, implementing, and evaluating HIV prevention interventions through the use of mass media, mobilizing community resources, and promotion of interpersonal communication in Sub-Saharan Africa. And his recent work has investigated how stigma towards people living with HIV and AIDS can be reduced through the media, how young girls in Africa can be empowered for educational aspiration, and how communication theory can be used for effective HIV intervention. And he currently works, and I have to say he really does currently work, in Malawi, Ethiopia, India, Nepal, and when we're lucky, in the United States. And we're very fortunate that he's not traveling right now and that he's here with us this afternoon, so please welcome him.
Thank you very much, Anne. Thank you very much for inviting me to this wonderful university, wonderful city. I've had the opportunity to talk with some of you throughout the day, and I've really enjoyed it tremendously. So thank you once again, and thank you for the invitation as well. As Anne mentioned, I am in the Department of Health, Behavior, and Society at Hopkins. The work that I'm doing, that I'm going to be talking about today, is work that emanates from one of the largest centers within the university called the Center for Communication Programs, or CCP, that has presence in lots of countries throughout the world. And the work that I'm talking about today, the work in Malawi, is being done through the auspices of that center. So I just want to acknowledge the role of that center. I'm going to talk a little bit about a little bit of background about the center itself and its role in global programming. Then I want to switch over and talk about health communication as well as risk communication, to put that in the larger context of international health. Then a couple of representative examples of health communication theory at work, and illustrative examples from our work in HIV/AIDS prevention in Malawi. So that's sort of the game plan. And hopefully this will be a nice journey that will take you from very individual, very small scale laboratory-based research, which I'll talk about, as well as national level surveys done at the household level, so spanning everything in between, hopefully. Without further ado, let me start by sort of just giving you a sense of what that Center for Communication Programs, where its tentacles reach, and these are the countries where CCP is either currently active or has been active in recent years, doing all kinds of work, and it gives you a sense of just the reach, from Bangladesh B, Zambia Z, and all the other countries that are represented there as well. The core areas of expertise of the center are represented here. So we do a lot of work on social and behavioral change communication, knowledge management, training and capacity building. So in order to leave a country after our intervention is over and empower people there to take it up and run with the programs that we've sort of helped them build. There's a lot of strategic advocacy in some of the countries, research and evaluation. That is an integral part of the center, as well as collaborative pedagogy with international universities. And I was talking with some of you, some of my colleagues here earlier today about the work that we're doing in Ethiopia with Jimma University, where we're helping them build their capacity to promote or to provide behavior change and qualitative research methods courses over the summer through a summer institute, with the idea being that after we do that for 2 years, the third year they'll offer it on their own. So there are lots of exciting opportunities internationally for that kind of collaborative effort. And I know that Drexel has been spending resources and looking out to expand its international reach. And I'm here to sort of say that, yes, absolutely do that, because there's a lot of demand for it. There's a lot of people willing to pay big bucks to have American university affiliations for their students, for their faculty, in fact. And this is absolutely the right time to be expanding and doing international outreach and collaborative work with other international universities. I'm constantly amazed by how much demand there is universities are building campuses in Kuala Lumpur, Addis Ababa, Nairobi, and all kinds of places. And so if Drexel is interested in sort of jumping onto that, I would say this is absolutely the right time to do that. Some of the projects that we are currently working on include things like avian and pandemic influenza, family planning and reproductive health, which has been the long staple of CCP's work in international health, global program in gender, HIV/AIDS, malaria, tobacco, water, and hygiene. So that these sort of gives you a sense of the kinds of projects that we do in the various parts of the world. Let me switch over to talking about health communication, because the Center for Communication Programs, the center that I was just telling you about, HealthCom is front and center in what we do, in how we think about our work, and the kind of footprints that we want to leave behind. So the question is, why health communication? Because it works. How? It works. It improves prevention and treatment for HIV, which is a big part of our portfolio right now. And as skeptics, you should say, well, show me the evidence that it works. I'll show you some. So from the larger literature in, the larger peer-reviewed literature, there's a study that's coming out, a meta-analysis that's coming out, or I believe it's just come out, that did a meta-analysis of 72 published studies that used mass media, so television, radio, and so forth, mid-media, meaning pamphlets, brochures, billboards, and interpersonal interventions, which shows significant average effect sizes for condom promotion interventions, and that these kinds of interventions, the effect sizes are larger in less developed countries, probably because the number of channels of communication is somewhat limited, so you tend to get a more captive audience when you've got fewer mass media channels, as we do in Malawi, which I'll talk about in a bit. They're also cost effective, because mass media, when mass media interventions are used and used in the mix, they just reach more people. And so you tend to, if they're well designed and well executed, you tend to get impact at the population level. Here's one example from a study that was done many years ago, I should say a series of studies that were done many years ago in the Philippines to promote contraception use among women, done by my colleagues at the center. And with a population, country population between 15 to 49-year-old women, the primary target audience, of roughly 11 million. The reach of the program, when we did the survey, 47.6% of the survey respondents reported high recall of the program, which translates to approximately 5 million women. There was a 3.6% net increase. That seems like a very small effect size, 3.6%, really? Are we jumping up and down with just that small an effect? Turns out, at the population level, that's about 196,000 new adopters with a total expenditure amount of $500,000, which works out to about less than $3 per woman reached and changed. That is, I will take that any day as an effect size. If I can spend $3 and get a woman to practice contraception, yes, bring it on. I'll definitely take that on. So then how do we, if we want to develop effective interventions, effective health communication-based interventions, how do we do that? Because they don't happen by accident, right? There's a lot of thinking, planning, implementation, and so forth that goes behind the scenes. And we tend to think of all of those sets of activities as being encompassed within this broad term that we use, which is strategic communication or strategic health communication. What do we mean by that? That it's grounded in theory and based on evidence. And theories come in many different forms. Here's just one way to think about theories, that on the one hand, or one extreme, you have a very individually focused theorizing. The theory of reasoned action, for example, is a very commonly used theoretical perspective in that regard, all the way up to diffusion of innovations or convergence theory of communication that seek change at a broad macro level. And depending on the problem at hand, the issues we're trying to grapple with, the behaviors we're trying to change, we might decide to come down in that continuum along a particular point to say, you know, this is what makes most sense for this particular issue at this time in this particular cultural context. But at the end of the day, what we are concerned with at the center is really changing people's behaviors. And when we're talking about changing people's behaviors, we're talking about strategically using communication channels at our disposal to bring about change at any of these levels that ultimately will impact behavior. So we could raise awareness, we could change knowledge, we could improve people's self-efficacy, we could advocate on behalf of people, we could change public policy, but at the end, the goal is ultimately to change people's behaviors. And then when we think about theory, it's much more useful to think of theory in a recursive kind of way, that, you know, it's not that you have a theory and that informs programs and then you're done and you go home, but rather findings from our programs, findings from our evaluation further reinforces the theoretical assumptions we make, the propositions that we're working with, and so forth. So it's a constant loop, and that's what keeps us in business. So let me end this segment by saying the way we think of communication is that we get very upset when people put an S at the end. We don't do communications, we do communication, and the primary difference is that communication with an S, we're talking about the products of communication like brochures and pamphlets and booklets and so forth. Communication we tend to see as a process. And what do we mean by that? That it's a long-term investment. That there is failure, there is success, it's iterative, we learn through our mistakes, we make better programming, we go out in the field, we succeed sometimes, oftentimes we fail miserably, we come back to the drawing board and say what went wrong, what could we have done differently, and so forth. Excuse me. And then at the end, come up with something that is our best shot, our best well-informed shot, best guess, for attempting to bring about change. Let me switch over. So that's sort of just a very broad overview of what the center does. Let's switch over to talking a little more specific about one aspect of health communication that's of concern to probably many people in this room, which is risk communication. And I want to, before talking more specifically about risk communication, put this in a somewhat larger context to say that risk communication, we can place that within a larger study of risk in general in society. So if we think about, out there in the environment, there are lots of factors that increase risk. The task then is for us to come up with ways of assessing that risk. So there's another body of work that focuses on risk assessment. Once we know what the risks are, or once we can get a handle on what those risks might be, then we communicate that risk to the public. Hopefully, through that communication effort, people perceive what their levels of risk are. So I am a 50-year-old woman. They're telling me that I need to go get a mammogram, so maybe I should start thinking about that, right? And then hopefully, if we convince people to modify their perceptions of risk, we bring about changes in their behaviors. Along that, we have different fields of study that focus on different aspects of this sort of decision tree, if you will. Risk analysis, maybe the risk analysis focuses on assessing what those risks are, relying on probability theory. And then once we know what those assessments are to communicate to the public, we are thinking about dissemination. And here, how we communicate about risk and how risk issues are framed have a bearing on that communication effort. Just because you communicate risk in a certain way does not mean people will perceive it in the same way as intended. So there are cognitive biases and people's abilities that come into play. And here we might think about health literacy, the cultural studies, all these disciplines sort of speak to that link between communication and perception. And then just because people have a certain perception does not mean they'll act. So there are abilities and constraints that come into play, and that's where behavioral theory would be relevant. So you've got a whole series of processes, disciplines, and perspectives that bear into this whole process of risk communication. Today I want to focus on sort of the bottom end of that decision and talk a little bit and show a few examples of behavioral theory at work in terms of how we get from risk perception to behavior change. Okay, so why study risk perceptions? One straightforward reason is that it's a central construct in many individually focused behavior change theories. They talk about threat appraisal, they talk about perceived susceptibility, perceived severity to a disease, perceived threat. All these are different terms that speak to the same idea that there is some sense that we are guided by our notions of risk. That when we are walking down a very crowded street, we instinctively wrap our hands around our purse. Why? Because we feel that we are at a high-risk zone. We need to do something to protect our risk, right? But to protect ourselves. So there is this notion that perceptions of risk guide our behaviors to a certain extent. I study risks and risk perceptions because I find it fascinating to look at how people play mental gymnastics with risks. Why is it that we build multi-million-dollar homes on the San Andreas Fault? Because it's not going to happen to me, right? Bad things happen to other people. So there's a lot of subjectivity in risk perception. We know from prospect theory, for example, that when it comes in the domain of gains, we want a sure gain. In the domain of losses, we're willing to take risks to avoid certain kinds of losses. But basically, for a communication scholar, what all this means is that how we communicate risk, how we frame risk is immensely important in how people understand that information. So communication scientists have a lot to contribute to risk communication. There's also a risk assessments are interesting and important also because there is a body of work that says that there are certain kinds of individuals who just are more prone to taking greater risks. So there's a sizable literature on sensation seeking as a construct that classifies people as high sensation seekers or low sensation seekers. So drug use during adolescence, for example, seems to be pretty well predicted by sensation seeking as a personality variable. It's also interesting to look at this kind of old study that I've always found to be fascinating. What the question that they asked, the Codrell et al. Study was, are adolescents in fact more risk-seeking than adults? And it turns out the answer is no. But what you and I define as risky is different than what adolescents and others might define as risky. So it's not that they're more risk-taking in their own eyes, but rather what they consider risky may be different from what you and I consider to be risky. So how the world appears from the actor's eyes and the meaning we give to the same social interaction becomes very important for us to think about when we think about risk. In the challenge in risk communication is that, as that example that I just gave you about, we build a multi-million-dollar home on the Andreas Fault, or the San Andreas Fault, speaks to this notion of optimistic bias. That compared to the average person, most of us think that we are not at risk. So, for example, if I were to ask you right now, compared to the average person, what is your level of risk in terms of getting HIV? How likely are you to get HIV compared to the average person? I bet most of you are thinking, well, not very much. I also imagine that most of you, in comparing yourself to that average person, have conjured up the image of that homeless person at the intersection of Cherry and whatever street, right? That when we compare ourselves to the average person, we're usually using a frame of reference that puts us in a very positive light. Again, that speaks to the level of subjectivity and the way that we think about ourselves that may be very different from what quote-unquote objective risk might be. The challenge in communicating risks, of course, is that it's very difficult to convey probabilistic information to the general public. What does it mean? How is it going to affect me? Our risk assessments are done at the average level, at the average person level, and all of us are above average, right? We all live in Lake Wobegon. Many hazards are unknown. But more interestingly, when there are new chemicals that are brought into the market, they do main effect tests. They don't usually do interaction tests. What does that mean? It means that there may be certain chemicals that may be shown to be harmless when working by themselves, but chemicals don't just work by themselves one at a time. They interact with the alcohol in our system. They interact with our stress levels. They interact with other chemicals. So what are the risks associated with these interactions? We really don't know. How does this particular chemical work if you live in a certain area that has a certain kind of pollution and you're of a certain age? I don't know that anybody's tested that before. So there's a lot of work to be done, obviously, in both calculating the risk, but more importantly for me, in how we communicate that probabilistic information to the general public. If I have a certain gene, does that mean I'm at risk for a disease? Maybe, maybe not. But those kinds of subtleties get lost in how we communicate, when we communicate to the larger public, particularly if we only have 30 seconds in which to do that. Findings from the research show that the empirical sort of link between risk perception and health behavior change is all over the map. There are lots of studies that show that, yes, if you heighten people's level of risk, perceived risk, that their behaviors will change. As there are as many studies that show that, in fact, the opposite happens. And there are studies that show that there is no relationship between risk perception and health behaviors. And you'll notice that there's a name in common, that the same author has found both things, right? So what are we to do of this? Should we just throw our hands up in the air and say, I give up? Actually, it turns out, whenever we see contrary evidence like this, there is a wonderful dissertation in the making. Let's try to figure out under what conditions. So it turns out the really bad question to ask is there a relationship between risk perception and health behaviors? The much better question to ask is, under what conditions do risk perceptions affect health behaviors? Because if we ask it in those terms, all of a sudden, we have many interesting projects to work on. There was a recent, I'll sort of speak more about HIV, 2005 meta-analysis that was done that looked at this relationship between risk. So what happens if you scare people? If you enhance their perceptions of risk? Do you then get them to wear condoms? It turns out that from these 354 HIV prevention interventions, risk or fear-enhancing interventions were least successful. You are much better off if you focus on changing people's skills or changing their attitudes towards the risk. Our own studies have given us pause in making that direct link between risk perception and health behaviors. We did a study among immigrant women in the larger DC, Baltimore metropolitan area and measured their perceptions of risk to breast cancer, as well as their cancer information-seeking behaviors, their breast self-exams, and their breast cancer screening mammography behaviors, and found basically that, for example, for women who perceive that they are at greater risk to breast cancer, their information seeking about cancer, the correlation was 0.13, very small. But when you included that in a multivariate model, that relationship disappears. So we found no relationship. For breast self-exams, none. For breast cancer screening, we found no relationship. In Malawi, which I'll talk about in more depth in just a second, the relationship between how likely you are or how likely you think you are to getting HIV and your propensity to use condoms, none. Or your propensity to reduce the number of sexual partners you've got, no relationship. So are we barking up the wrong tree? Why are there these divergence in findings? Well, one straightforward methodological reason might be that, well, there might be third variables at play, right? That it may be that, when you enhance people's risk, they get fearful, they bury their head in the sand. It's not going to happen to me. Or they go out and seek do the right behaviors. It may also be that risk has a positive, the enhancing perceptions of risk has a positive behavior, tends to produce positive outcomes among people who feel that they can do something about the risk, and among people who feel that they can do nothing about it, why bother? So it has no relationship among those groups. It may also be that, we often, up to now, I've been talking about perceptions of risk as being the cause and not the effect. We've been assuming that, yeah, if you scare people, they'll go out and do healthy things. But could it be that if I ask you, what is your risk to heart disease on a scale from 1 to 10, in answering that question, you're thinking, well, let's see, I don't smoke. I'm on the treadmill for 15, 20 minutes every day. I eat a pretty good diet. I eat fruits and vegetables. I don't have a history of heart disease in my family. So actually, you know what? My risk is pretty low. Which says that for that person, behavior came first and perception followed. That I am looking at my behavior, at all the things that I do, and perceiving that my risks are low. So it may well be that when you do a survey and you ask people what's your perception of risk and what's your, what kinds of behaviors are you engaging in, that you've got both things going on. That some people may be giving you that response based on what they've done, and for other people their perception might precede their behaviors. And when you lump all these together in one cross-sectional study, these effects are going to wash out. And so you need longitudinal studies at a minimum to detect these effects. I'm going to now take you back to a tightly controlled laboratory setting where we did a series of studies when I was at the University of Texas, where we actually manipulated perceptions of risk and perceptions of efficacy to look at people's behavior. So we brought students to the lab and we asked them, okay, list 3 things that you have done, that you continue to do on a day-to-day basis, that puts you at risk for skin cancer. Simple manipulation. Just write down all the things that you do. So half the people were asked to list these activities and half the people were not. And then we had them read essays around skin cancer prevention that focused a lot on all the things that people could do to prevent skin cancer or not. So we manipulated perceptions of risk and we manipulated perceptions of efficacy to see what would happen to these 4 groups that are defined by these 4 categories. So in the first group, you've got someone who thinks, you know what, I don't do anything that puts me at risk, or my perception of risk is very low, and even if I were to be at risk, there's nothing I can do anyway, so why bother? And we call them the indifference group, low risk perception, low efficacy beliefs. The avoidance group, oh my gosh, I didn't realize I did all these things that put me at risk. It must mean I am at risk, and I've not been told all the things that I can do to protect myself. And so therefore, the best thing for me to do is bury my head in the sand. It's not going to happen to me. Why? Because it's too uncomfortable to think that I'm at risk and there's nothing I can do about it. The proactive group is the group that thinks, you know, I'm not at risk, but even if I were, there's a lot that I can do to protect myself, so I'm going to go ahead and do all these things. And for the responsive group, this is the group that thinks, yeah, I am at risk, but there are things that I can do to allay my concerns. There are lots of things that I can do. So in a high HIV prevalence country where we work, this is where we want people to be. They are at risk to HIV because it's all around them. But at the same time, there are solid things that they can do to protect themselves. So in this particular experiment, where we manipulated risk and efficacy, we then gave people access to websites on skin cancer to see where they would go, how much information seeking they would do, and then at the end, we gave them a knowledge battery to test how much knowledge they gained as a result of their seeking information. So you've got in this sort of experimental lingo, a 2-by-2 experiment with a 4th control group that got neither the risk nor the efficacy manipulation, right? Here's what we found. Basically, so for people who were, let's see if whose level of risk was low, if they had higher levels of efficacy, they were more likely to seek information than if they had lower levels of efficacy. For people whose level of perceived risk was high, we found just the opposite. In the group that we were calling the avoidance group, which is this guy here, this group here, was in fact seeking more information than we had predicted. So my first reaction was, of course, to say to my graduate assistant, go back and recode that data. I don't believe that. I'm joking. Which she did and said, no, in fact, this group turns out the group that we'd been calling the avoidance group turns out was anything but avoiding. They were out there seeking the most amount of information. When we asked them, how likely is it that in the future you're going to wear sunscreen, you're going to wear protective clothing, minimize your time out in the sun, that group actually gave us the most healthy response, contrary to our predictions, right? Which is your first reaction, is to say, oh my gosh, I'll never get this study published. But then after you get over that shock, then you say, maybe there's a kernel of interesting nugget lurking here. So basically what we found was that efficacy does modify the relationship between perceived risk and health outcomes, but not quite in the direction that we thought it would. So our first reaction was to say, well, maybe what happened was that people kind of freaked out. Oh my God, I'm at risk. There's very little that we can do. So I'm going to go out and seek information to either show the researchers that they're not correct, or to find out information about what I can do. We did this. So we thought, well, maybe what happened was that skin cancer, most people know lots of things about skin cancer. Let's try to see if this can be replicated in another domain. And in this case, we did it for diabetes prevention and basically found the same thing. So it's nice when you replicate, but it's also kind of freaky when you can't quite understand what's going on. But in this now, I want to point to this information, point to this slide where you've got high levels of risk and low levels of efficacy. That's, so they're seeking more time on the websites. They're jumping to more websites. The amount of time that they spent on these websites is much higher. But look at this. The level of knowledge is not as high as would be predicted by the amount of time that they spent. So our sort of post hoc theorizing about this was that they were freaked out. They were jumping from one website to the other, but they weren't able to retain as much knowledge as perhaps they should. Which for us has very important implications. If you're a physician and you have to tell your patient, you know what, I have bad news. The test came out positive. So what that tells us is that at that moment, your level of anxiety of your patient is probably going to be really high, depending on the kind of disease we're talking about. And all the important information that we're about to give this patient at that particular time is going to go completely above their heads. So at a minimum, what we need at that point is somehow we need to find a way to manage the anxiety, because unless you manage that anxiety, nothing that you say subsequently is going to mean anything to the patient. Then in study 3, we tried to replicate this finding in a naturalistic setting where we surveyed people, and this was again done in Texas, around the issue of skin cancer, where we did engage in a telephone survey in that particular research community among 300 people. And here the findings were much more in line with what we would have predicted, which is that the high-risk, high-efficacy group sought much more information about skin cancer, and the low-risk, low-efficacy group sought the least amount. The other two groups were somewhere in the middle, much more in line with our predictions. Use of sunscreen, basically what we found here was that if your level of efficacy was high, your tendency to use sunscreen was much greater. Risk perception mattered in a different way, that if your risk perception was low, efficacy was low, you did not use sunscreen at all. You tended to use sunscreen if your efficacy was high. Right? So risk mattered more than efficacy when the variables were manipulated. Efficacy mattered more than risk in a naturalistic setting. And that so we've sort of gone off on a tangent, sort of trying to answer that question: what is really going on? How, anytime you get different findings based on the methods that you've adopted, you tend to put less credence on those findings, right? Because your findings should not be determined by the methods that you use, which then raises very interesting questions about, well, what could have accounted for those discrepancies? So one thing that we think is going on, though we don't know for sure, is that perhaps in a laboratory setting, we're not manipulating the magnitude of risk, we're manipulating the salience of the risk. That is to say, people are basing their decisions on risk as opposed to something else in a laboratory setting when we've heightened their risk. Whereas in a naturalistic setting, we're not, when we're walking around and doing our day-to-day things, we're not being guided by perceptions of risk. It's much easier to be guided by our perception of efficacy. Can I do certain things? Yeah, I can do it. So, I don't think I can get an A in that class, so I'm not going to take that class. This is a class that I can get an A in, so I'm going to go ahead and sign up for that class. And I would assume that many of our decisions on a day-to-day life basis are being made on the basis of our efficacy perceptions. Let's go back to Malawi, which is sort of one area where we've been testing this theory. We did a household survey in 2004, right before we started our campaign. And this gives you a sense of, what that survey looked like. 36% of our population had no education, 49% had primary education or less, roughly half females. And when we tested the same model here, in terms of, here the outcome variable was their intentions to use condoms at the next time they had sex. And here what we find is a big main effect of efficacy. That people who felt efficacious in their ability to use condoms were much more likely to say that they were going to use condoms. If they didn't have efficacy, they weren't going to use condoms. Perceptions of risk, you'll notice here, matters not a whole lot. We redid that survey 3 years later with our midterm evaluation of our intervention, and basically found, again, a main effect of efficacy. This was knowledge about HIV. People who felt efficacious had gone out, sought information, gained more knowledge about HIV. And for condom use, again, we see a main effect of self-efficacy. That is to say, this green line, which is the strong efficacy group, had higher levels of condom use. What is interesting is that if your efficacy was weak, if you did not think that you could propose using condoms with your spouse, which is how we measured efficacy, then if your perception of risk was high, your tendency to use condom was even lower than if your perception of risk was low. In other words, this is, for this group, right, you know what, there's no way I can propose using a condom with my spouse. What will he think of me? What will she think of me? I don't have the efficacy to do that. So if you tell me that my risk to HIV is very high, I'm going to bury my head in the sand kind of thing, right? So I'm not even going to think about using condoms at all. So that has important implications for message design, which is that if we're going to promote a fear-based appeal, we have to be very careful about raising fear needlessly among people whose efficacy is low, because you're going to get counterproductive effects. Nevertheless, what all these studies are showing us is that self-efficacy is by far the most reliable predictor across these behaviors that we've got. This is our self-efficacy basket, where we're putting all our eggs. Let's go back to Malawi, because I want to spend a few minutes talking about some of our work there. Here's Malawi, small country, Southern Africa, 13 million people, one of the 12th poorest country in the world. You can see 14.4% HIV prevalence. That's the average. In the southern part of the country, in certain regions, it's as high as 20%, which means that, this sort of was brought home to me when I was there for the first time. Someone, in a hall like this, there were about 100 people that came for our initial dissemination talk. And it sort of hit me that, oh my gosh, probabilistically speaking, about 20 people in this room are HIV positive. All this paints a very dire picture of Malawi. What these statistics don't show is that it's also one of the warmest countries that I've ever been in terms of the hospitality of the people, the sheer welcoming nature of individuals. It's one of the best countries that one could go to just to sort of mingle and have a good time with people. People who don't have very much tend to give 100% of what they've got. And we've used the same model there as well, as I just indicated, to look at these four groups. And over the course, the life of the campaign, what we have attempted to do was to move everybody to that cell, bottom right-hand cell, to enhance their perceptions of risk, to get them to acknowledge their risk, but then at the same time promote their self-efficacy as well. So the research questions that in this project that we're asking is, can we move individuals to that responsive cell number one, and number two, does doing so matter in the long haul? So our campaign strategy has been to increase risk perception, but focus mostly on efficacy enhancement. This comes from a 6-year, the data that I'm showing you comes from a 6-year project in Malawi from 2003 to 2009, where we've been working. That used really a multi-level approach using community mobilization, mass media, in this case radio, pamphlets, booklets, all this stuff, working with religious institutions, local, district, and national AIDS organizations. And this gives you a sense of the kinds of things that we've been producing. So we work with radio, there's pamphlets, booklets, all this stuff, community mobilization, and then we work with targeted, there are smaller scale interventions that happen, what we call targeted interventions. In this case, we've done 3 of them to enhance people's sense of efficacy. We also have an intervention specifically targeted towards grandmothers, because they're called the agogos in Chichewa, and because they are the primary sources of information for young girls. And we also work with youth organizations through soccer clubs and things like that. Ndita in Chichewa means I can, and that's our central self-efficacy enhancing message. So everything in the campaign comes under this logo of Ndita to enhance self-efficacy. And we approach self-efficacy from the perspective of, not my efficacy to reduce my risk to HIV, which means nothing, but rather we come at it from the perspective of enhancing proximal goals. So my efficacy to do very small, what we call doable steps, to keep a condom with me. That's it. That's all we're promoting. Can you just keep a condom with you at all times? Can you purchase a condom? Then we have specific trainings on how do you initiate discussion with condoms with your partner. How do you talk about condoms with your child? Right? So these are very proximal goals to enhance people's sense of self-efficacy. And I should note that this campaign started in 2003, some 5 years before the Obama campaign. So we've done a series of research evaluation activities starting from 2003, 2006, and 2007. We had midterms, and then in 2008 we had the end of the project survey. And I want to show you this just to show you sort of the extent of the evaluation work that has gone in. We measure self-efficacy through these items. What's your confidence in your ability to remain faithful if you're in a relationship, to remain abstinent if not in a relationship, to use condom during sex, to talk to your partner about condom use, to reduce the number of sexual partners. And here's what we have found over the life of the campaign. So your efficacy to remain faithful at baseline on a 5-point scale was about so high, and then it jumped up at the first midterm and then remained flat after that. Your efficacy to remain abstinent if not in a relationship, baseline, it jumped up, and then something happened here, and we've been scratching our heads all these years trying to figure out what happened. We don't quite know, to be honest. Now we know that there were other campaigns in the region, so we're not the only guys doing work, but something happened there to reduce efficacy for abstinence, but then it went back up again. But the overall sort of trend seems to be that, that first few years, everything jumped up, and then it sort of hit a ceiling, if you will, and it's been, it remained there. So this is the efficacy to reduce the number of sexual partners and so forth. That's the first observation. The second observation is that among all these different behaviors, efficacy to use condoms is still a challenging one. That's the one that can still show improvement. Risk perception, what is your belief that you're vulnerable, that you could get HIV? And we measure that in terms of, what's the likelihood that you could get HIV in the next 6 months and in the next year? And perceptions of risk have also shown the same sort of effect, right? So you see an initial jump, and then it remains the same for both of these measures, your next 6 months as well as next year. So in terms of our four-group division, here's what's happened. At baseline, here is the indifference group. This is the group that has low risk, low efficacy, right? And we're trying to move everyone to the responsive cell, if you remember. The responsive cell in the beginning was less than 10%. By the end of the project, we see about 40% of the people that moved to that group. And then the other two groups, there's some movement there as well, but really, I think the big thing for us was, to get this group that thought, I'm not at risk, there's nothing I can do anyway, I don't really care, to get them to think about, no, I am at risk, but then there's a lot that I can do. So did it matter? Well, for some of the behaviors that we care about, so the likelihood of getting tested for HIV, which is one of the big behaviors to reduce prevalence, among the low risk, low efficacy group, here's that group, that's the indifferent group. Here's the responsive group. So clearly, if you have high level, so this is data from end of the project. You see better effects if you're in that responsive group. You're more likely to have gotten tested. But we also see the same thing for the proactive group, which is the low risk, high efficacy group, again, showing the effects of efficacy. So it seems that if there's a way to enhance people's level of efficacy, that's what we should really strive for. And this is a slide that I've shown you before. At the end of the project, again, we see this big, so the high efficacy group is above the low efficacy group, first finding. Second finding, the best thing that you could do is to get people to have high sense of efficacy and high sense of risk. If those two things work together, then we see greater use of condoms. So how do you enhance efficacy? I don't need to get into this. Social cognitive theory has these four solutions for enhancing efficacy. You focus on their, you get people to practice a task that increases in level of difficulty, then you have them reflect on that, on what they've been able to accomplish and so forth. The role of communication, changing harmful norms, creating a supportive environment, that's sort of one of our primary goals. Let me come at it. So that's the risk and efficacy framework. We've also been working on promoting an open environment to promote discussion about HIV, to get parents to talk about HIV, to promote positive health communication among the population. And did that effort work? Well, so here's the data that shows the power of discussion. So I should also mention that one of our strategies throughout the campaign has been to promote open dialogue, to get religious institutions to talk about HIV. One of our high achievements, which won't show up in any journal article, was about 3 years into the intervention. On one of my trips to Malawi, I was in the southern region, and one of the pastors in a local church said to us, you know what, I thought long and hard about this. I think we will allow you now to use our church to have your discussion groups. And boy, it took us 3 years of hard work to get to that point, but that was a watershed moment for us. That finally the church itself, and I should say that Malawi is predominantly Catholic, that the church had sort of come around and said, yeah, you know what, we can't just turn our sort of blind eye to this epidemic. Okay, we'll open the doors. You can come in and talk about condom use. And we thought, wow. So promoting that kind of dialogue was, we've seen as key to our efforts. And I think what this data here shows is that, so this is kind of a lot of things going on here. Let me just show you a couple of highlights. So on the y-axis is your likelihood of getting tested for HIV. This is people who talked about HIV prevention a lot, or people who did not talk about HIV prevention with their fellow neighbors. this group is group that was exposed to our campaign, high exposure group. This group was not exposed to the campaign. This is group that had a medium level of exposure, right? What you see is that people who were exposed had higher levels of testing, fine, but the slope of this line is greater than the slope of the other two lines, meaning that if you were not exposed to the campaign, but you talked about it with other people, then you were much more likely to get tested. So if you weren't getting information from our intervention, but you were talking to other people in your community, then you tended to have positive outcomes. So what can we do to promote dialogue, to promote openness, to promote discussion in the community? That's sort of our concern. This is condom use as an outcome, and we see very interesting results here as well. That, again, if you were exposed to the intervention, then the more you talked, the better your likelihood, or greater the likelihood that you would use condoms. So there was this sort of, more exposure meant higher condom use. But look at this, that I should say, oh, I'm sorry. So in this case, we're talking about community. Let me back up. This is level of discussion. The three lines pertain not to our exposure. I misspoke. So this is, you live in a community where there's average level of condom use is high. You live in a community where the average use of condom is kind of medium, and you live in a community where the average use of condom is low, right? So if you live in a place where lots of people are using condoms, discussion was helpful. If you live in a community where condom use was low, discussion was counterproductive, somewhat, right? And if you live in a community where condom use was kind of medium level, then there wasn't that much benefit you got from talking to others. Which further shows that the campaign to promote discussion should really be happening, and that there's this sort of synergistic effect that happens, that after people start engaging in positive behaviors, the discussion in those communities tends to have very positive outcomes. So overall findings that we see influence of individual level determinants of risk perception and efficacy beliefs, and social determinants heightened through community engagement. Interventions need to tap into and stimulate community discussion and engagement. And hopefully, so our effort is ongoing. We've just started our second phase of the campaign. So the data I showed you was from the intervention from 2003 to 2009. We now have another 5-year grant that's going to be working there for another 5 years. So we'll be done in 2014. And hopefully, and this time we're focusing on, the first phase of the campaign was on individual level change. Now we're focusing on community level change, and we're collecting data now at the community level. Hopefully we'll see same kinds of effects, but at a more macro level. And I want to thank all my colleagues, funders, partners who've helped us in this effort. And thank you for sitting through this long talk. Thank you very much.
In regards to the efficacy surveys, were you guys controlling for those who were exposed to HIV or AIDS, or had a partner or somebody else closer in their family who were exposed that might have possibly caused that raise in education or change in behavior?
Can you specify what you mean by control for?
What I mean is, did you take out of the survey? So for example, let's say I'm a participant and then all of a sudden I get HIV/AIDS. I'm going to be much more likely to go to the reactive stage, right? The responsive stage, rather.
I see. So my answer would be yes and, that's a great question, by the way. My answer would be yes and no, in the following sense, that for IRB reasons, we were not allowed, we didn't seek permission to ask for people's HIV status, number one. So we don't know whether or who in our survey was HIV positive. However, in the question that asks, in the next 6 months, how likely are you to get HIV? And in the next, I think, lifetime and next year, how likely are you to get HIV? The interviewers were instructed, so there was a small box that said, I'm already HIV positive. So we weren't allowed to volunteer that, but if the person said, oh, I'm already HIV positive, then the interviewer sort of checked that box, and then we took those people out of the sample in all this analysis. But that was a very, very small sample of people who acknowledged that they were HIV positive, so it was a handful. So the answer to your question is, I don't know. Okay. I don't know what would have happened if we had a more reliable sample of people who were HIV positive.
Thank you.
But I can certainly see where what's interesting is, I mean, your question reminds me of another study that we're just about to undertake, which is that at the testing centers where people come to get tested, what we have found is that we often give people survey before they get tested, or before they get their test result. So some people while they're getting tested. We ask them a lot of questions about their prior behaviors. How many sexual partners have you had? Do you use condoms? Right? All those kinds of questions. And then what we have found is that people who have led a very high-risk sexual behavior lifestyle, when they test negative, they construe that to mean, oh my God, that must mean that I'm immune. Because here, look, I've led this very high-risk lifestyle, and yet I'm negative. And so, so the danger is that they would go out and do high-risk behaviors, engage in high-risk behaviors. And from an ethical standpoint, we have safeguards in place for counseling for people who test negative. I'm sorry, for people who test positive, but we don't have anything for people who test negative. I was talking about this with a sociologist friend of mine who used to be at Penn, who works in Malawi, and she said, well, in the qualitative work that we've done, we found just the opposite, that people who test negative, who've lived a very high-risk lifestyle, say, oh my God, I've been given a second life. I've been given a second chance. And so they actually change their behaviors to sort of, in the positive direction. So we're actually about to embark on a study that is going to see who does, one of these two things. Because I think there's something very interesting going on there in terms of, what people do and how they modify their behaviors when they see that they're testing negative.
Hi, thank you so much for the discussion today and everything. My question is about the next phase of your study, since you said it was focusing more on community level factors. And admittedly, I don't know really much about Malawi at all, but you said it was a very highly Catholic country. Mm-hmm. So I don't know if already sort of reducing stigma or opening discussion up about homosexuality has been a part of that, or if it will be part of the next phase. And I'm also curious if any questions in your the first survey address that.
So we're not allowed to ask any question about sexual orientation. The local IRB board in Malawi would not approve that study. So that sort of gives you a sense of the environment where we're working, right? And so we've not, now I have a colleague at Hopkins who studies this phenomenon, has done a study in Malawi, but that's a very different study because the sampling for that is very different. And there's a lot of sort of underground work that happens. So in our study, we don't ask that question at all because we're not allowed to. Having said that, the second phase of the study is focusing much more. Now we're working in the southern part of the country, which has the higher prevalence. The northern part of the country is relatively lower prevalence, so we're not working there. And in the southern part, there is a greater mixture of Catholic and Muslim groups that live sort of side by side. So the interventions for the ones that use churches and mosques look somewhat different because they're sort of tailor-made to the particular community. But our unit of analysis, unit of intervention in this case is going to be smaller village communities. So now we're working with women's groups, youth groups, churches, and so forth, to see, if we can get people to think collectively and sort of harness that collective efficacy, if you will, then can we see greater multiplication of effects. So we don't know whether that's going to have those effects or not. So have we looked at resilience? We haven't looked at resilience as a concept in that exact way. However, we work with, there's one small, I talked about targeted intervention. So there's one small group, one small part of our project in one district that works with HIV positive children. And there, I assume that resilience would be a very important construct. But we still come at it from a social cognitive theory kind of perspective and think of it, at least in our heads, in terms of efficacy and collective efficacy. But I think there's a lot of overlap, obviously, with resilience, because how you construe your experience, what meaning you give to the traumatic experiences that you've lived through has a big bearing on your efficacy and your resilience, obviously. But that's but thank you for that, because I know there's a whole body of work behind that term, and I think we could probably benefit from going to some of that literature as well. Yeah, thank you. Yeah.
Okay. So recognizing that self-efficacy is so important, I was just interested in some of the interventions, some specific interventions that you have come across that were important to you in your work, and I just wanted to learn about those.
Sure. So a couple of very simple interventions that we have done are actually informed by, there's a couple of studies that have published this where we actually got the idea, so it's not our original idea. But that is really, and it comes from social cognitive theory, which is we bring women women who are sexually active, who've expressed their inability to initiate condom use, and we do exercises where it's all scenario, role play kinds of things. So the term that social cognitive theory uses is cognitive rehearsal. Right? So it is, okay, so you've got a condom with you, your boyfriend does not want to use it, so what can you do to start that discussion? Oh, I can't start that discussion because what they think of me. And then we have role models. It's, no, but you know what? Actually, if you presented the information this way, I've had, so it's those kinds of activities, right? So there's a lot of that kind of cognitive rehearsal. Then there is role modeling of, so one of the things, I showed a very brief description of it. It's called the Tisenkenji radio program. And that Tisenkenji radio program is a serial drama. It's radio-based, that is based on the life of a 14-year-old girl who lives in Malawi and goes through this experience of having teachers proposition to her for a grade, which sounds horrible, but we've had instances of girls sort of saying that. And then, and she's freaked out in the first few episodes, and she doesn't know, she can't confide to anyone, and she finally tells a friend, and, so we've sort of modeled the right behavior for her to do, throughout. And at the end of the 22nd episode, so it's 22 episodes long, she finally does the right thing, and, the two sort of very positive feedback from the community. And this is a radio drama that is broadcast half an hour every week during the school hour. So the school sets aside time to listen to this. So they bring all the girls together. It's broadcast on the radio. There's a matron, what they call a matron, a female teacher, that then, it's all girls only. Then we have published comic books that are based on each lesson plan for each episode. So we say, for this episode, what are the questions that, that would stimulate discussion among that group? And again, it's all about efficacy enhancement. So what if, I can't tell my father, but can you tell your uncle? Can you tell your aunt? Can you tell, and so we stimulate discussion through these questions. So we found that enhances self-efficacy like you wouldn't believe. When they see that they're not alone, that there are others like them, that there are in fact solutions that they can undertake, and that they have allies. They have allies who can be called upon. So we presented that paper at a conference 2 years ago that's under review. Hopefully it'll get accepted. Yes.
In the campaign to reach out to communities about efficacy and risk, how would you address the discriminated minorities or mobile nomadic groups or just communities that are far away from the civilized, I guess, groups? Or is that even a problem for Malawi?
In Malawi, there are two two groups that have been identified as being at high risk, very high risk. One is truck drivers, so the mobile communities, truck drivers, fishermen, these are considered to be high-risk groups, and sex workers, right? So we've got the government of Malawi. So one thing that I didn't talk about here, because I didn't want to sort of muddy up the waters, is that a big chunk of our effort is really directed at empowering the local, state, and national government of Malawi to do interventions. So we bring them, we do the leadership training, we do HIV efficacy enhancement training, we do all kinds of stuff, and then they go out and do the intervention. So there is a whole series of interventions that is being done with commercial sex workers. And now in Malawi, most commercials, no, I shouldn't say most, there is a significant proportion of commercial sex work that happens where condom is being used. We know that for sure. So those are small interventions where we've done that kind of work. Now, apart from those groups, we've not worked with other highly stigmatized groups. There are other very vulnerable groups, for example, orphans, who are mostly orphans of HIV parents. And boy, I mean, there is so much to be done. And, I feel like sometimes, we're just one small drop in the bucket of the larger need that exists in the country. But, we're constrained to some extent by the funder who says, I want to spend money doing this, with this population. And so far, it's been the general population that we've been after. It's not been the more marginalized populations. But there's certainly, that's not to say that there's not work being done. There certainly is. So for our second phase of the project, when the RFA, the request for applications, was put out, they put out 2 applications. One was for a project to work on a generalized population, which was us. We finally won that. But our sister project was to work with marginalized populations. And PSI, the Population Services International, is the other agency that won that project. So they're working with fishermen, they're working with truck drivers, sex workers, and so on.
Thank you very much.
Thank you. Thank you very much.
Thank you all for coming. We will see you at upcoming lectures after the new year. Have a great holiday. Good luck on exams.